4-port technique is still the standard and considered the safest in laparoscopic cholecystectomy. However, we all know that the number of ports is not the only factor that makes it safe. Patient's condition and anatomy, severity of gallbladder disease, and the operator's experience all affect the surgery's outcome. Here in our country, there was an evolution. For the past 2 decades, as experience and learning increases, so is the number of surgeons doing 3-port laparoscopic cholecystectomy. Yet, the morbidity rate is the same, if not decreasing. Personally, I don't mind having extra 5mm scars as long as I don't become a biliary cripple. But nowadays, patient satisfaction includes the lesser number of ports, especially young patients. We all know that we never compromise safety over cosmesis. If difficulty arises, one must not hesitate to add another port, either for surgical exposure, for control of bleeding, or for assist in suturing. My first solo laparoscopic cholecystectomy is back in 2005, using 4 ports. And after several years, I have slowly transitioned to 3 ports, and I have been confident, even for difficult gallbladders. In Cabanatuan City, where I am now practicing, I met Dr. Joselito Tantoco, an expert in MIS, and he taught me how to use a multiport. This is similar to the ones we use in single-port laparoscopy, and he was able to reduce the number of port incisions to just 2, the umbilicus and the epigastric area. And so I gradually changed my routine laparoscopic cholecystectomy to just a multiport at the umbilicus and a 5mm epigastric port. And there are things that I have learned, and that is why I am showing this video today. We recommend to start with uncomplicated cases, but if it becomes difficult, you can always convert to 3 or 4 ports. You have to be well trained in 3-port laparoscopic cholecystectomy before you attempt this technique. Other methods of 2 ports are with the use of needlescopic graspers as the third instrument, transabdominal sutures to lift the gallbladder, and some even place multiports at the epigastrium. For uncomplicated cases, we routinely start with just 2-port incisions, an umbilical multiport, and a 5mm epigastric port. Most cases, no additional port sutures or other instruments were needed. The multiport we use has 3 or 4 ports, similar to those used in single-incision laparoscopy. We recommend using a slender 5mm 30-degree scope to create more space for movement at the umbilical port. It will be helpful to use long graspers to lessen crowding near the umbilical port. We can place the scope either at the 7 o'clock or 10 o'clock port, and the grasper usually at the 4 o'clock. We can rotate the port as needed. I usually place the scope either above or below the grasper and rotate the scope angle to better visualize the field. This can only be done if the fascial incision at the umbilicus is at least 3 centimeters. You start with a 2 cm skin incision at the 12 o'clock instead of the 6 o'clock. I find that this creates less torque at the umbilicus and lessens post-op pain. A transumbilical incision is also possible, but only done for very shallow umbilical pits. It is important to lengthen the fascial incision at the linea alba. Place the wound protector. At this point, you can actually see inside and can immediately inspect the bowels underneath the umbilicus. Now, one of the advantages of this port is you can place an entire gauze instead of just strips. Place the multiport in this configuration. Scope and graspers are inserted at 10 or 7 and 4 o'clock positions, respectively. This is how it looks from the outside. Notice that your left hand instrument is actually closer to your body compared to the routine 3 ports. This has an ergonomic advantage. Fencing between the scope and the left hand grasper can be diminished if you will use a 5 mm scope and a long grasper, and creating the umbilical opening as previously described. Place the gauze at the subhepatic area lateral to the gallbladder. This helps in the exposure and cleaning of the surgical field. After inspecting the landmarks, estimate the degree of difficulty. This is the time you now decide if you will add transumbilical sutures, needlescopic graspers, adding a third port and a fourth port. But in this case, this was not necessary. You now proceed with achieving the critical view of safety. Place the scope below the grasper and take your time to estimate the location of the common bile duct. Just like in 3 ports, you can actually mobilize the Hartmann's pouch with just the L hook. Of course, this must be facilitated with counter traction of the left hand grasper. Again, this 2 port technique can only be attempted by surgeons who are well trained and has a long experience in 3 port lap calling. Dissect the surgical plane to mobilize the Hartmann's pouch and achieve the critical view of safety. Notice also that rotating the scope facilitates angulated viewing and lessens the need to move the left-hand grasper. You can now continue dissecting the superior medial serosal attachments by positioning the scope above the grasper. Once the critical view of safety is achieved and 0 BDI timeout is done, clipping of the cystic artery and cystic duct is easy using 5 mm pliers. Not shown was my routine draining of the cystic duct before double clipping to ensure there are no small residual stones at the cystic duct stump. With the scope at the superior placement, the gallbladder is dissected off the liver. At this point, we can remove the specimen by just pulling the gallbladder out from the umbilical port. Final inspection is done for hemostasis, check for bile leaks and visceral injuries. Epigastric port is pulled out under direct vision, and the gauze is also pulled out from the umbilical port. This is an easy cholecystectomy case. For experienced three-port surgeons, this will take a short amount of time, if not faster. Before and after closure is shown, and excellent cosmesis is achieved.